Guys, let us look at direct hernia. Basically, in direct hernia, what is happening? The contents are coming out through a weak wall, okay? It is not using any path like the inguinal canal, etc. So it is not using this inguinal canal as a path to come out. It's not that. It is directly coming out because the wall which is posterior to this inguinal canal, that wall is weak. So it is directly coming out. So it is direct hernia, okay? And what is coming, guys? It will be the internal organ, right? So that is what will come out. That's why it's called as hernia. So what is there here? The Hasselbalch triangle, okay? So it comes through that. So the weakness in the posterior wall of the inguinal canal, that is the transversalis fascia. So behind that, right, the posterior wall, through that it comes out. Where? In the Hasselbalch triangle. What are the boundaries of this Hasselbalch triangle? Let us look at this. So you can see the boundaries of the Hasselbalch triangle. So look at this, guys. Medially, what you have here? Medially, for this triangle, you have the lateral wall of the rectus abdominis muscle. Very good. Then inferiorly, you have this inguinal ligament, right? Inguinal ligament. And laterally, you have some vessels. So let us look at the what is there in this Hasselbalch triangle. Medially, lateral wall of the rectus abdominis. Yes, laterally, the inferior epigastric artery. Below, you have the inguinal ligament. Okay, so we are talking about direct hernia. So what are all hernias, you know? So the direct hernia will be something like this, right, in the Hasselbalch triangle. So what will be there when you are trying to approach it? What and all will come your way? Skin, 2 layers of superficial fascia, external oblique aponeurosis, then the conjoint tendon, fascia transversalis, and peritoneum. So look at this here. So where will your indirect hernia be? So this is the inguinal canal. So definitely it's not choosing this route. It is directly coming out, right? So what and all will you encounter? You will have the skin, 2 layers of superficial fascia is nothing but your, is it the campus and the scarpa's fascia? Then you will have this external oblique aponeurosis, then internal oblique conjoint tendon, right? Then fascia transversalis. And then you will have the peritoneum. So you understood, right? What and all, in direct, what and all you have. So basically in indirect, what you had extra, you had this cremasteric fascia between this, see here, this brown one, cremasteric fascia also you had extra. So why does direct hernia happen, guys? Remember, mainly it is the weakness, right? Weakness of your transverse abdominis or congenital absence of a few fibers. All this will be responsible for direct hernia. Remember, weakness. There should be weakness of what? Here they are saying transverse abdominis. Where is this? Here you have the transverse abdominis, isn't it? And these people will be having some increased abdominal pressure. Intra-abdominal pressure will be more, chronic cough because of bronchitis, etc. or tuberculosis. So they will be popping this hernia on cough. They'll have some difficulty pass urine because of some BPH, etc. and hence they will be straining themselves. Constipation they may have, so they're straining themselves. They're increasing their intra-abdominal pressure, right? Smoking also, because they have decreased strength of abdominal muscles because of decreased elastin. So don't smoke, guys, if you don't want hernia. Guys, then you have Ogilvie hernia. So basically that's a type of direct hernia. So there is a circular defect in the conjoined tendon. Okay. So guys, did you understand? So basically here the hernia is where it is somewhere here, right? It is nothing to do with the scrotum. Guys, let us look at the differences between indirect and direct hernia. So basically indirect is what? Let us look at the easy ones here. Look at this. The sac comes out through the deep ring. Here the sac comes out through Hasselbalch triangle. This much we are clear because here it is using the inguinal canal, right? Then see, here it's coming out through a canal, right? So what will happen? The neck will be narrow, so it can get obstructed and strangulated. Here, there is no canal as such. So the neck is wide, so it may not get obstructed and strangulated, looks like. So basically, what is the relationship of the sac to the cord? Which cord are they talking about? Spermatic cord, is it? So it is anterolateral to the cord. And in this case, direct hernia, it is posterior to the cord. Now look at this one, internal ring occlusion test. So when you have the internal ring here, so first you will reduce the contents and then you will put your thumb on the internal ring and close it. So what will happen? We'll ask the patient to cough. that time the indirect hernia will not be seen because it needs the internal ring to come out, isn't it? So it won't come out, but the direct hernia will come out, right? Swelling is seen in direct hernia. On standing, it does not pop out because it is in the canal, but this one pops out, okay? Then this is unilateral within the canal, and direct hernia is usually bilateral. That's interesting because there is weakness, is it? So it will just come out of both the sides. See, this direct hernia needs a weak abdomen wall, right? So it usually is in elders, right? And indirect hernia can occur in any age. It will just find a path indirectly, right, to come. So it will use the canal or some path. So that is why it can occur in any age, right? So in direct hernia, you will have this Malgine swellings, bulgings. What is that? So in the leg raising test, they have spoken about this, or in the head raising test. Okay, so basically weakness of the oblique muscles is manifested by these bulgings above the medial half of the inguinal ligament. Do you remember yet another difference in examination you have seen, guys? So basically in the internal ring occlusion, you saw that the direct one will come out because it doesn't rely on the internal ring as such. But what about the external ring? When you close the external ring with your finger, right, the tip of the finger, you will feel the inguinal hernia. It will come and touch the tip of the ring, the inguinal hernia. But the direct one will come and touch the pulp of the finger, right? Did you understand this? Who will touch the tip of the finger in the external ring when you're occluding? The inguinal hernia. The direct one will touch the pulp of the finger. The right word is the external ring invagination test, okay?